the SNTC, and today's moderator, Dr. David Ashkin. Dave?
Karen, thank you so much. We are, as always, very excited about today's presentation. It's a special one. Karen, as you said, this week or early this week, we're going to be presenting and we're going to be acknowledging World TB Day. World TB Day celebrates the 131 years since Robert Koch made his discovery and his announcement that found the etiology of tuberculosis, the mycobacterium. And I sometimes think about what that was like at the time and how it pretty much shocked the world that this disease that once was the leading cause of death had now found its cause. And with that cause, we were now able to begin to figure out what we could do to control tuberculosis. And since the 131 years that have passed, tremendous achievements have been accomplished. I mean, just this year alone, in the last 2 years, the amount of new diagnostics and new treatment have really pretty much, gone beyond what we ever could have imagined. But on the other hand, I have to say, even with all this, we're still not there. I think we'd all agree that while we've made accomplishments and while we've had achievements, we're still far from controlling this disease. Luckily, as we'll hear, the number of cases in the United States is again falling, and we're really proud. It's the lowest rates and numbers we've seen since we started reporting it. And worldwide, we're starting to see even some decreases in the numbers and the deaths. But TB is not finished yet. I think we all agree we're far from it. And one of the things that have really, challenged all of us is how tuberculosis is changing with the times. 131 years ago, Robert Koch, when he made his announcement, one of the things he didn't have any clue is how TB was going to change its face and change its host so that it continues to challenge us. And 131 years ago, the topic we're going to talk about would have pretty much marveled most people listening. The idea that we could take organs from one person and put it into another person so that they could live and live normal lives was beyond the imagination. It's still a miracle today. But one of the things that have really challenged us is that TB has now changed its face. TB is now a problem with those individuals who either are donating their organs or receiving those organs. Not only is it a problem in that it's causing diseases, but as clinicians, it's challenging us. It's challenging us to rethink this disease, to rethink how we diagnose this disease, and how we manage and treat this disease. Over the last couple of years, I think more and more of us are recognizing that this technology, this treatment that was once seen only in major medical centers is now coming to our homes. No matter where you are in the United States, wherever you are in the world, you will now start to see individuals who have been or are thinking about receiving or undergoing transplantation. And as we'll hear about today, these individuals are posing issues and challenges. We owe it to them to make sure that we diagnose and treat these individuals so to allow them to never have to worry about getting TB, or as importantly, if they have TB, making sure they're managed and they can live normal, healthy lives. And because this issue is definitely becoming one that is affecting all of us, we've asked Dr. Michele Morris to come today to talk about the diagnosis and management of donor-derived infections concerning TB and transplantation. I'm so proud. I mean, Michele Morris and I have gone back a little while. I've had the opportunity to just sit in her office like I'm doing today and just talk about cases and talk about the issues, and she's educated me so much about it. Michele is currently the director of the Immunocompromised Host Service at the University of Miami. She's an associate professor of clinical medicine with the Division of Infectious Disease. Yes, that's true, infectious disease. I hate introducing infectious disease. Us pulmonologists, whenever I'm sitting here talking to her, I always have to admit how much I learn from her, and I hate to do that, but she's been a tremendous mentor. Michele, as you're probably aware or may not be aware, was the chairperson of a very, very important consensus statement that just came out in the American Journal of Transplantation, which was a joint statement from the American Society of Transplantation, the Canadian Society of Transplantation, as well as the Transplantation Society, which is an international group. I'm really so pleased to welcome and to introduce Dr. Michele Morris. Michele, take it away.
Thank you so much. I want to thank the Southeastern National Tuberculosis Center, with a particular thanks to Dave Ashkin and Donna Setzer for the honor of presenting this information today. And hopefully I'll be able to figure out how to advance my slides, which are not advancing yet. Let us see. Okay, we'll try this. Okay, if we go full screen, will we be okay?
Sure, go ahead.
Let's see, and we'll see if this works. So I'm going to speak to you about a topic very near and dear to my heart, tuberculosis and transplantation, focusing on the diagnosis and management of donor-derived infection. As you can see here, there's a lot going on in transplant, and these surgeons who are gutsy enough to pull the heart out of someone and put a new heart into them really need to focus on what they're doing and can't always deal with the details of the many pathogens and other disease processes that can be transmitted through transplantation. So we're going to focus on some of those challenges today. I'll be discussing giving you some background about the epidemiology of TB as it relates to transplantation. I'll review some of the epidemiology of donor-derived tuberculosis, and then I'll discuss some information or share some information that may be new to many of you, the details of the organ procurement process, so that you understand better the timing and challenges we face and the difficulties that are incurred with deceased donor screening. After that, I'll move on to diagnostic testing in deceased and living donors. And finally, we'll discuss management, something you may have already been asked to do as TB experts, both management of potential donors and of organ recipients. Just a bit of background, some of which may be familiar to many of you. Mycobacterium tuberculosis infects 1 out of 3 of the world's population. Partially because of this, tuberculosis is now one of the most common bacterial causes of solid organ transplant donor-derived infection reported in the United States, which is traditionally felt to be a very low TB incidence country. And the incidence of post-transplant TB really varies country to country, but is described in various publications in the literature as 20 to 74 times higher than in the general population. So transplant recipients are a very high-risk population for TB. The incidence varies from 1% in Germany to 13.7% in a country like India. And one of my colleagues, who is a transplant specialist in India, shared the fact that at this point at their center, 30% of their transplant recipients develop tuberculosis. So extremely significant problem there. In the U.S. and Europe, the incidence varies from 0.35% to 6.6% overall. And one of the particular challenges is that between 1/3 and 1/2 of post-transplant disease is disseminated or extrapulmonary, so that it's very difficult to diagnose. Now, I'm going to be focusing today on a very small percentage of post-transplant TB cases. Those are the cases that are donor-derived, transmitted through the organ allograft to the recipient. And one of the reasons that we're seeing more issues related to TB is well described in Thomas Friedman's excellent book. He's a New York Times columnist, many of you may know, who talked about the fact that the world is flat. We now have globalization, and with globalization, we are sharing a lot of problems. We're seeing increased tuberculosis risk in low incidence countries, particularly through immigration. I practice in Miami-Dade County, Florida, and it turns out that between 65 and 70% of full-time legal residents of Miami-Dade County were born in another country outside the United States. This does not include people who live here illegally, who are resident aliens. These are full-time legal residents, and these include our transplant donors and recipients. In addition, Miami's a big travel destination, and world travel is an issue. And in fact, Lori Garrett, in her wonderful book about emerging infections, The Coming Plague, discussed the fact that you can wake up one morning in the jungles of Africa, in Mumbai, India, in Seoul, South Korea, and go to sleep that night in the Midtown Manhattan, New York City, in Los Angeles, California, in Chicago, and bring with you in your body all sorts of pathogens that can then be disseminated. So this has caused an increased TB risk here and in low incidence countries. Conversely, in high incidence countries, we're seeing more and more availability of organ transplantation, and we're transplanting using donors and recipients who've been exposed to pathogens like TB. Well, what happens when a transplant recipient gets TB? Well, unfortunately, mortality rates are up to 30% and actually may be higher in low TB incidence countries due to delayed diagnosis. This is not always a diagnosis that's thought about. Morbidity also occurs, including the loss of the transplant allograft. Part of the reason for that is the treatment challenges involve complex drug interactions with immunosuppressive agents. One of the most commonly used immunosuppressants, tacrolimus or Prograf, interacts very significantly with the rifamycins, rifampin and rifabutin, and transplant rejection can result when TB treatment is employed, and there are multiple other interactions with multiple immunosuppressive agents. Just to review the sources of TB in transplant recipients, donor-derived TB, the focus of today's talk, really is the least common. Transmission occurs through the organ allograft. This is likely more common in lung recipients for obvious reasons. We're transplanting the organ of entry, the portal of entry for this bacteria into the body, into the recipient. The most common source of TB is reactivation in recipients with untreated or unrecognized latent or active TB. And though part of my job every day is to screen recipients at risk and try to treat potential recipients pre-transplant, that's not always possible. If someone has fulminant cardiac or hepatic failure, we barely have time to find an organ for them. We can't screen for every pathogen necessarily pre-transplant. And then, of course, post-transplant exposure poses a risk. This is more common, of course, in high TB incidence countries where the general population may be walking around with active tuberculosis. So we're going to take our tour of the flat world, and you're forced to look at my vacation pictures. As we go into donor-derived TB cases, we're going to visit the Golden Pavilion in Kyoto, Japan. And I will introduce you to some history. This is a very well-publicized case that the CDC published in their Morbidity and Mortality Weekly Report. And this is the donor history. And you'll note in this history that this donor was U.S. born, but had multiple risk factors for tuberculosis that are familiar to you. This donor was an alcoholic, homeless, and had recently been incarcerated. And in fact, medical history noted that he had been treated for pneumonia 6 months before death and retreated again 1 month before death. PPD skin testing was negative at both admissions. No AFB testing was done. The patient presented for admission of what was to be his final illness with seizures, altered mental status, and aspiration pneumonia. Was felt to be an episode of alcohol withdrawal, and ultimately he went on to expire due to cerebral vasculitis and became an organ donor. Now, part of the evaluation before he died included lumbar puncture CSF sampling, and 3 weeks post-transplant, the spinal fluid grew Mycobacterium tuberculosis. Unfortunately, at this time in the United States, when someone dies and becomes an organ donor, cultures and pre-mortem studies are not labeled as such. And so presumably the lab had this culture result that came back, and they called the treating physicians who said the patient expired, and that was the end of it, until someone remembered that this was an organ donor. And this took some time. So that 6 to 7 weeks after death, the organ procurement organizations and transplant centers were finally notified about this culture result. And unfortunately, donor and recipient TB sequencing matched, implying what did occur, there was a transmission. And this is the publication that I mentioned. So let's look at the 3 recipients. Now, it turns out that organ donors can donate organs to up to 8 or more recipients and tissues to up to 100 and more recipients. So in this case, thankfully, only 3 solid organ recipients were involved. And let's look at how they presented. The first one was a 50-year-old female kidney recipient who presented with fever, pancytopenia, and sepsis 6 weeks post-transplant. Not your usual presentation for tuberculosis. And bone marrow AFB was positive. So the patient was diagnosed, this recipient, and treated, but died 9 weeks post-transplant. Blood, liver, spleen, and lung cultures all matched donor TB typing. The second recipient was a bit younger, hopefully a bit healthier, presented with fever and headache 7 weeks post-transplant. Again, not your typical presentation for tuberculosis. Wouldn't be top on your list if you were practicing in 2007 in Oklahoma or Texas. Perhaps you might think of donor-derived infection with this early presentation, but maybe you'd think of West Nile virus, which has clearly been transmitted through transplantation. Spinal fluid AFB was actually negative. Bone marrow had granulomas, but was AFB negative. The kidney biopsy was AFB negative, but mycobacteria grew from blood and urine and matched the donor strain, and this patient fortunately survived. Then we go to the liver recipient, a 59-year-old male who had the good fortune of being started on a treatment 2 months post-transplant when the word was finally out to his transplant center that there had been a transmission. The patient never developed symptoms, and a liver biopsy done for unclear reasons 7 months post-transplant was TB culture negative. So you can see here the challenges of diagnosing donor-derived tuberculosis in a transplant recipient who has an unusual presentation, a multitude of other infectious possibilities, and not uniform transmission to all recipients. Let's look at a publication that reviewed some cases of donor-derived TB in the literature. And you can see the clinical presentation is very variable. We have pulmonary, genitourinary, miliary TB. We have graft TB abscesses. Wouldn't be the first diagnosis you'd come up with if a transplant recipient presented with a foot granuloma. A very unusual presentation turned out to be donor-derived TB. And granulomata in the graft, the transplant graft. And you can look at the outcomes. Unfortunately, there's graft failures and deaths reported. So this is a challenging and highly morbid infectious disease. And then we look at the donors. We have living-related and cadaveric, now called deceased donors. And you can see even living-related donors can transmit tuberculosis. And looking at the TB status of the donor, some were known to have latent TB by skin testing with normal chest x-rays. One had no evidence of latent TB and had a culture that grew MTB 3 weeks post-mortem. You see that here. You can see situations where the chest x-ray is normal, but both recipients develop the same strain of tuberculosis, or the chest x-ray showed some high-risk changes like calcifications and apical opacity in a donor that was from an endemic area. So it's really quite challenging to recognize a high-risk donor and either avoid using those organs or appropriately manage the donor and recipient. Now, because of the challenges, we need to have some definitions to know when did TB come from the donor and when did it come from exposure post-transplant or reactivation in the organ recipient. And the U.S. government has come up with a whole lot of language around this issue of donor-derived disease, such that any disease present in the donor that is transmitted to at least one of the organ recipients is felt to be potentially donor-derived. Thankfully, this complicates less than 1% of all transplants. And these diseases don't just include infections. There are many unrecognized malignancies that can be transmitted to a recipient in an organ allograft. And these also are donor-derived diseases. All of this is heavily monitored and regulated by UNOS, the United Network for Organ Sharing, OPTN, the Organ Procurement and Transplantation Network, and DTAC, the Disease Transmission Advisory Committee. And I'm going to present this information from a U.S.-centric perspective, but those of you on this webinar from other countries, I can assure you your countries have similar or maybe even more elegant and sophisticated monitoring systems. Now, it turns out that for those who are practicing in the United States, you are actually subject to national law OPTN policy since November of 2010 that mandates that when an organ recipient is suspected to have, confirmed positive for, or has died from a potential transmissible disease, or a medical condition for which there is concern that it could be from donor origin, this must be reported. This is law, and the transplant program must notify the host organ procurement organization by phone and provide documentation as soon as possible within 24 hours of knowledge of this transmission. And this is to prevent some of the outcomes that we've seen, particularly in the first case I went through. And so if you as a TB practitioner find out that there is a recipient with tuberculosis, it's very important to get on the phone, on the internet, and trace down where these organs came from and put up the red flags, let everyone know. Then DTAC, the Disease Transmission Advisory Committee, has to look at whether this was donor-derived. And diseases are classified as expected or unexpected because some things are known to be transmitted through transplantation or part of the risk of transplant. And the probability of donor-derived infection. A proven infection is one where both the donor and at least one recipient have a matching pathogen. A probable transmission is where one or more recipient is infected and there's suggestive data about the donor. Possible transmissions include potential cases prior to 2008, so prior to DTAC investigation, or cases where there's evidence to suggest but not prove transmission. And what we're hoping to do now is make all transmissions potential, where no transmission occurred. This is typically because the appropriate organ wasn't used or when we've recognized the risk and prophylaxis is used to prevent transmission. This is an adaptation of the DTAC guidelines to tuberculosis, and you can see the specifics of proven transmission with laboratory evidence of infection and pre-transplant testing indicating that the recipient had no evidence of MTB prior to transplant. Probable transmissions as listed here, and possible cases where a single recipient may develop M. tuberculosis, but there's no proven donor source, although there may be suggestions of a donor source. So these are the kind of cases that we'll sort of be reviewing today and the ways they were defined specifically. Now, DTAC published some of their donor-derived infectious disease transmissions in the American Journal of Transplantation in 2011. And of note, there were 26 donor reports of mycobacterial infection. 10 of the cases had confirmed transmission, and 2 had recipient deaths, making MTB the most common type of bacteria resulting in ID transmission that was reported in this country at that time. Just a review of U.S. donor-derived TB cases. This is based on governmental data. As of September 2012, there were 30 cases that they looked at, either from DTAC or in the literature. Interestingly enough, 4 of these cases were from living kidney donors, and living donors are relatively easy to screen. They're as easy to screen as other healthy people. Only 17% of these recipients died, which is better than generally reported. But remember, these are recognized cases where the diagnosis was made. It is not always made in an early death post-transplant. In all of these cases, diagnosis was delayed and extrapulmonary disease was common. So even though we're aware of the problem and are monitoring for it, it is a challenge. Now we're going to move on to Peru, to Machu Picchu, and I'm going to talk to you about organ donation and donor screening. So this will be a little bit different approach, something maybe new for many of you. Just a few facts to get you started, and these are available from the American Transplant Foundation. It turns out that more than 115,000 people in the U.S. are currently on the organ transplant waiting list, and it varies day to day and week to week between 115 and 120,000 people. Another name is added to the transplant waiting list every 12 minutes, and on average, 18 people die every day from the lack of available organs for transplantation. 7% of people on the waiting list, that's over 6,500 people each year, die before they are able to receive a transplant. One deceased donor can save up to 8 lives through organ donation and can save or enhance over 100 lives through tissue donation. And I would be willing to bet that there are folks listening to this webinar now who either personally have donor tissue or even organs in their body, or have a close friend or family member who does. All of you who've had anterior cruciate ligament repairs, who've had bone grafts from your back surgery. A lot of those tissues, corneal transplants, came from these very generous organ and tissue donors. So these donors are very important to the people waiting for organs and tissue, and we want to use as many of these donors as we can safely use. But we need to screen to make donations safe. Potential organ donor screening is very challenging in the deceased donor. It's done under the auspices of the organ procurement organization locally. They're usually contacted by an emergency room or intensive care unit and brought in to evaluate the prospective donor and obtain consent from family members. After that, a detailed history and physical is obtained by the OPO representative. Our local history sheet is about 15 pages long. Sometimes the people that are being asked these historical questions know very little about their loved one who has suddenly often become brain dead and become an organ donor. And they're also very distraught and grief-stricken. So this is a very challenging process. During this process, contraindications to donation are ruled out, and donor testing, including infection screening, is initiated. In the meantime, the donor is maintained in the ICU setting on a ventilator with IV fluids to keep the organs appropriate for transplant. And in the background, recipient identification occurs based on the size of the donor, their blood type, ABO compatibility, and immunologic factors. All of this is tightly regulated in the United States by UNOS, such that recipients who are most in need and local to the appropriate organs are asked to accept the organ donation. Medical history does not just focus on infectious disease, but even the infectious disease aspects are complex. We're asking grandma, who is across the United States and the only relative we can find from this 20-year-old IV drug abuser who just became brain dead after an overdose, or the parents who live in South America and whose child was just hit by a car and killed, about previous infections, vaccinations. Did they ever work around people who had TB or hepatitis? Where have they traveled? Did they ever have a blood transfusion? What kind of contacts did they have with HIV, hepatitis B, or hepatitis C? Did they have tattoos or body piercing? What kind of drug use occurred? Imagine you're called from halfway around the world. You're all distraught about your brother or sister who's basically brain dead in an ICU, and you're asked about their drug use history and sexual behavior, whether they were ever incarcerated. This is extremely challenging and delicate work that the OPO representative does. And then there are all sorts of unusual infections transmitted through transplant. We have to ask about bats and stray dogs. Many of you may have heard about the recent rabies transmission in Maryland 1 year post-transplant that was donor-derived. Did they have any pet rodents? We have infections like lymphocytic choriomeningitis virus that are transmitted from pet mice or laboratory mice. So it's really a challenge. And deceased donor history is obtained from relatives who are distant or uninformed. It's often inaccurate, both because these people are very upset and because they really don't know some of the more maybe secret details of their loved one's life. We would think living donors are an easier group to screen, but living donors are often relatives or close friends, and they may not wish to disclose to this person that they're very generously donating their kidney to that they actually spent a little time in jail 10 years ago, or when they were in their 20s, they snorted cocaine 1 week a long time ago. They may not know of their risks. They may have had a sexual contact that they just don't want to talk about and share. And so donor screening really is challenging. And unfortunately, it has to occur in a very, very narrow timeline. So we get a referral of a patient on a ventilator who's brain dead, and our wonderful Life Alliance Organ Recovery Agency here in Miami, headed by Susan Gans, who's a very meticulous and wonderful leader, has her group come in and obtain consent. And then we have between 6 and 48 hours before the organs have to be in the recipient, a very short period of time during which the potential donor is given medication and stabilized. Laboratories, including cultures, are obtained, echocardiography on potential heart donors, bronchoscopy on potential lung donors and other donors where a concern about TB is raised, and the organs have to be placed and they have to be flown to the receiving center. It's not always around the corner from the donor site. And the patient who is the recipient has to be ready in the ER to receive the organs. So it's really a very, very narrow timeline during which all this screening for infections such as TB have to occur. We're relying, therefore, on some standard facts about the donor that help us screen them. The major donor risk factor for TB is country of origin, and if they're from a country of origin with a TB incidence greater than 100 per 100,000, we know they're high risk. And some would consider anything greater than 50 per 100,000 an endemic TB area. We look at the social risk factors, homelessness, incarceration, alcoholism, or known TB contact. Unfortunately, many of these social risk factors may predispose someone to die young with very good organs and be an excellent organ donor if they're not at risk to transmit infection. And then we look at medical risk factors, a history of untreated TB, radiographic evidence of prior TB. This can be very helpful, but remember who an organ donor might be. It may be someone who has survived their motor vehicle accident. Cars are much safer now than they were 20 years ago. So many people survive the initial accident with head trauma and live in the ICU for a couple weeks before they're declared brain dead and become an organ donor. During that time, they may develop pneumonia or other infections, or they may have pulmonary contusions from the accident. And you can't see the granulomas on their chest x-ray past all the other changes. Or they may be a drowning victim, and you really can't tell what's going on their x-ray. We look at risk factors like a body mass index less than 18.5. Again, some of the people who die young may not have had the best nutrition. We look for diabetes and cigarette smoking, medical risk factors that are very common in this country. And we look at the risk by organ transplanted, lungs being the highest risk to transmit tuberculosis. The U.S. government has shared risk factors for TB in individuals from low-risk regions in their living kidney donor recommendations, and they include some significant, rather newer risks, significant time in areas of the world with high rates of TB, being defined as greater than 3 months. It's becoming more and more common with the global flattened world for people to do relief work in a country with high TB risk, either as part of their high school or college education, as part of their work for their church or local charity group, and be exposed and not know about it. There are also people who reside or work in an institutional setting, which results in increased risk of exposure to TB. And I would suggest that a majority of people on this call may be considered part of this high TB risk group. And then we have NANES data that talks about risk among U.S.-born persons for TB. Interestingly enough, older age is a risk factor because people may have been around and living when TB was more commonly circulating in the community. And this is a very important thing to consider as our donors are becoming older and older, again, because we're better able to help people survive motor vehicle accidents and other head trauma, and we're relying on older donors in general. Now, many of you are familiar with the estimated TB incidence rates around the world, and I, as a practitioner in Miami, Florida, whose population of donors, 70% of whom come from this area, include a lot of high TB risk areas. And so I have to think about TB incidence rates of the donors at the time they left potentially this country of origin. But that's a little tricky. Really, TB risk by country of origin is a moving target, and just to share a scenario that occurred, I was involved in the Donor-Derived Consensus Conference, and we published our report, including this table of TB incidence by country of origin, in September 2012 in the American Journal of Transplant, and received a letter in about November from Spain, our colleagues in Spain, stating we are no longer a high incidence country. In fact, we have an incidence that's about 6 per 100,000, much less than 25 per 100,000. So as part of publishing this erratum that was published in 2013, January, I looked over the list that we had pulled together in 2012. Every single one of the countries in bold had a changing incidence. They had moved one category or more in their TB risk. And this was in a short several-month period. We have to look at the risk by country of origin from our donor when they lived in that country of origin. And this is done by transplant specialists, not TB specialists. So it's really a challenge to figure out, oh my goodness, they're from North Korea. There's a lot of TB there now, but there wasn't so much TB, at least reported, a few months ago. So it's really a moving target. What we drill it down to is the most important risk factor for TB in the U.S. is country of origin. The latent TB incidence in U.S.-born persons is 1.8%. And for foreign-born U.S. residents, it's 10 times higher, 18.7%. That's a huge risk factor, and in my catchment area, that's 70% of our organ donors. So it is a challenge. So we have to optimize testing. We have our deceased donor on life support, and we have to decide what infections we're going to test for. So you have just tragically lost your 2-year-old in a drowning in the backyard pool, and we're going to tell you that you can't have the funeral for 2 days because we're testing them for HIV and TB and hepatitis. You may decide to withdraw consent for organ donation so you can get on with funeral plans. Spin that a little more. You're in upstate New York. It's winter. It's blizzard, and we have to fly these specimens to Boston so that the proper tests can be done, not only as an issue of delaying the funeral on your child that you know is not at risk for TB, but organ procurement delays occur awaiting test results, and the very precious lungs and heart of this child are no longer appropriate or available for donation. Testing is not always available at remote centers. We have organ donors in every hospital in North America, but testing cannot necessarily be done in all these centers. My OPO has 81 hospitals in our catchment area, and we're a fairly urban part of the state. So we have delays in organ procurement getting specimens to do them a lot and do not have qualified people on call 24/7, 365 when we activate someone as an organ donor with these 6-hour time clock ticking. If we get inaccurate results and rule out a donor, we've lost all those organs and we have more people dying on the waiting list. So it's really a challenge. And we also have laws about what tests we do. If an FDA licensed, approved, or cleared screening test is available for a particular disease, it must be used. And if it is positive, if we find out that there are conditions in the donor that are risky for the recipient, these conditions that may be transmitted by the donor must be communicated plane flying to Atlanta. The recipient in Atlanta says, look, I'm not that sick, I don't want this risk, and now the plane has to be diverted to North Carolina. So this is a very complex process with a very short time window. And these are just some of the known conditions that may be transmitted by the donor organ that must be communicated to the transplant center prior to transplantation. And you can see active tuberculosis is kind of middle list. There's lots of bad things on this list that can be transmitted through transplantation, and we don't have a lot of time or a lot of testing available to make these diagnoses. So it is truly amazing that only less than 1% of all our transplants are associated with a transmission. We have to decide, therefore, what donor testing is appropriate. We look at the epidemiology of the disease. Is the incidence sufficient to justify testing? Is the prevalence of the disease high enough in donors to make the positive predictive value of the test reasonable? If we test for something in a low-risk population, most of the positive results we obtain will be false positives, and we may rule out an organ donor who's a very excellent donor and basically eliminate recipients from a chance of living. We also have to look at whether an infection or a disease is transmittable by organ transplant, and if so, are all organ recipients at risk? And we want to look for diseases for which there is a significant morbidity and mortality, for which either prophylaxis or treatment is available, which is the case with TB. And we want to test where there's a testing platform that exists for screening. We don't always have a test that works in a deceased donor. We always have this scale we have to look at. How safe is safe enough? We have to weigh patient safety, the safety of our organ recipients, with organ availability. Are we sentencing people to die on the waiting list if we make transplant completely safe? We are, in fact, transplanting organs from a human being that we cannot sterilize. And so this is the constant challenge. And what we're left with is a compromise goal, which is risk stratification. We know that risk is higher with active infection. So we ideally do not want to use donors with active infection who will clearly be high-risk donors. We really don't know the risk for latently infected donors. And so we try to figure out who may pose the greatest risk for transmission of TB. and use that to risk stratify. And this varies country to country, region to region, and in fact, time to time. Unfortunately, this stratification may not allow us to eliminate every donor who's high risk to transmit tuberculosis, but it is a tool to help determine how aggressively to pursue a diagnosis of tuberculosis in febrile patients post-transplant. This is not a diagnosis we always entertain. We've had a transplant recipient who presented with a painful swollen red knee post-transplant. TB would not be first, second, third, fourth, or fifth on my differential diagnosis at the community hospital where this person presented. But that's exactly what it was, and that's how it presented. So it really is a challenge, and if we had flagged this person, their donor was high TB risk, maybe not high enough to treat the recipient, at least it might have been thought of sooner. So now it's time for you to answer some questions, and I will turn it over to the high-tech experts who can help me here.
So what we're going to do, if it's okay at this point, is to get a better idea of exactly what your situation with transplant is. We'd like to ask you a couple of questions if you don't mind answering, and we'd really appreciate it. So I guess the first thing is a very basic, which is what is your profession? And I know that we have sites where there's multiple people watching. Put all your professions in. It's okay, but it will help us out to get a good idea of exactly who's out there. And one of the cool things for us is this really allows us to interact with you and to know who's out there. So as you can see here, it looks like about 60%, and keep going, you're doing great, but about 60% of the audience are nurses. We see about 17% are others, and 20% are physicians approximately. So I think we have a very nice mix. We have about 8 to 9% epidemiologists, about 2% administrative staff. So it gives us kind of a good idea of who's watching, very broad. And it's, I think, Michele, very interesting that, it really just shows, just like you're saying, how complex this is and how many different disciplines, just like in the transplant procedures and scenarios, just dealing with the TB aspects, you see all the varied backgrounds of individuals who are called into it and are interested. All right, let's try the second question, if that's okay. And thank you, guys. That's great. So question number 2 is, have you been asked for guidance regarding the management of transplant patients with latent or active TB? And again, please choose more than one if you're there. I know we have multiple. So it's so we're seeing it kind of change rapidly. So what I think is interesting is, I think if we asked this question 10 years ago, the vast majority would have clearly been no. I mean, very few people had much interactions with either transplant donors or transplant recipients. I think what's really interesting is you're seeing now that close to 22% of all the audience, right, are individuals who've had some interaction with transplant recipients, interestingly enough. And I think that makes sense, because I think the transplant donors, in a lot of ways, is really the centers that are pretty much, where the organ is coming from. And I think that's really more the transplant, team themselves. It is still, I would say to you, about 65% of individuals are saying no, but I'll just give you the numbers, Michele, so you can see 65 are saying they have not had any opportunity. About 7% were for potential transplant donors, 22% were transplant recipients, right? And then about 15% were both donors and recipients. So I think you're seeing more and more individuals, it surprised me, close to 35% of individuals watching, and remember, this is a broad slice, have been called in to have some sort of dealings with either recipients or donors. All right, thank you again, guys. And last question, if it's okay with you. The last one, nope, I'm sorry about that. There we go, thank you. Which of the following TB treatments have you been involved with for transplant recipients? I like some people who just jump right on to this. I feel like I'm on a Jeopardy game show. It's amazing. Even before I've read the question, I mean, we're getting the answers. But The questions are, no real involvement, but either with treatments for TB latent infection or high-risk exposure without active TB, active extrapulmonary or disseminated TB, and then solid organ recipients from a high TB risk group. And Michelle, what's interesting is that, again, what we're seeing is the vast majority of individuals, about interesting, about 35% have been asked for some advice for latent infection. And I take it, it's kind of interesting, and we'll find out a little more, I take it that's latent infection of both individuals who are waiting the transplant as well as, I guess, questions of, individuals who, may have, I guess, been screened prior, though I think we'll talk about later. About 26% are active pulmonary TB, so like you're stating, quite an issue with that. And then 18% are active extrapulmonary or disseminated TB, and about 10% are individuals with high-risk exposure without active disease. And again, 48%, they haven't been asked yet, but I do really mean this. Just like we've seen this tremendous increase in the last 10 years where I think these numbers would have been markedly, this is really changing. And as you heard, and as we'll be talking about, as transplant becomes more and more common, I think we're all going to be in some way, or most of us will be in some way involved. So, Michele, first of all, thank you all for responding. We can't thank you enough. And if it's okay, Michele, I'm going to turn it back to you. Now that you've got a little better idea, now we're going to go on to the rest of the talk. So thanks, Michele.
Thank you, and thanks to everyone for giving us your answers. Let me see if I can get it to go forward. I have lost control. Maybe I did that. I got my thing back. There we go. Okay. We're going back to Japan for TB diagnosis in the transplant donor, something you may hear about. We've talked a little bit about using history and physical exam, emphasizing epidemiology, but what about diagnostic testing options? Well, certainly imaging is used, and abnormal chest x-rays can be very helpful if suggestive of TB, but unfortunately, due to trauma or underlying disease, the things that brought these people to become potential donors, we may not be able to tell what's behind all the other things happening in their chest x-ray to see if they have evidence of old TB. Tuberculin skin testing is great when somebody actually remembers the result. I spend about a third of my weekly clinic treating potential recipients and living donors for latent TB, and virtually none of them remember their prior tuberculin skin test results from years gone by. Interferon gamma release assays like QuantiFERON TB and ELISpot tests have revolutionized latent TB diagnosis, but unfortunately have not in any way been validated in deceased donors, though we definitely use them in living donors. And I'll talk about some of the challenges related to that in a minute. Clinical specimens can be very helpful. AFB smears and cultures, nucleic acid amplification. They're highly useful, but unfortunately, results virtually always return after the organs have been placed. So they're useful for treating the recipients, but the recipients have already received the organs. Most of you are familiar with the details on this slide, looking at QuantiFERON TB Gold, T-spot TB, intracellular cytokine staining, which is really developed by Martina Sester, the head of the Eurozone TB Net, who is working diligently to try to develop transplant donor screening for our deceased donor, and of course tuberculin skin testing. You'll notice the real problem here is time needed. We're on that timeline with deceased organ donation, and in virtually every case where a test, even if it was feasible, could be done, the shortest time is 8 hours, and this is in one lab in the world that I'm aware of, and that's Martina Sester's lab in Hamburg, Germany, where she's tried to look at this performance in deceased donors in ICU settings. And unfortunately, performance of these tests really isn't known, or there's very limited knowledge. All of these interferon gamma release assays, cytokine staining, rely on the immune status of the host. And if you're a brain dead host, or you are in the ICU with head trauma, or prolonged ICU stay with some severe life-threatening infection, your immune system is not functioning terribly well. And when we compare the tests that we have, we again look at these turnaround times. And we know these tests are feasible and used in living donors at many centers, but we really have indeterminate results in immunosuppression, which is extremely common in deceased donors, and really impossible to perform tuberculin skin testing in deceased donors. The only data we really have on interferon gamma release assay performance in the deceased donor comes from the veterinary literature, because to really know if someone has latent TB, you basically need to do a full-body autopsy post-mortem. That is something that we can't get approved by any research location. It's completely not done in humans. But the cattle industry has struggled for years with diagnosing bovine tuberculosis. And they have a gamma interferon assay, which they tested and then looked at their cattle, and they found that blood collected post-mortem resulted in reduced sensitivity for the assay. And any test of IGRA performance in humans who are the type of human that might be a organ donor, that is a ICU patient or someone with brain injury, has shown poor performance. So this is really our challenge. In fact, the Consensus Conference looked at these data and found insufficient evidence to recommend use of these tests. The results are usually not available in 24 hours. In the best studies, there's a high rate of indeterminate results, up to 16%. Repeat testing really is not feasible because of the timeline. And we know that cell-mediated immunity, which is required to respond to these tests, is depressed after head injury, causing a non-response to the mitogen control. In addition, IGRA use in pediatrics is still controversial. And the most important issue is it really doesn't distinguish between latent and active TB. So you would have to, if these tests perform perfectly, which they don't even in the healthiest of persons, you'd have to rule out 1 in 3 of the population of the world as organ donors, something we really don't want to do with people dying every day on the transplant waiting list. In addition, positive tests in a low-risk population may represent a false positive. These tests are useful in living donors because, first of all, we have a sense of their risk. We can get a history. Where are they from? Where have they lived? Where have they worked? They are presumably a healthy donor if they're giving up their kidney for a friend or relative, so the test performance should be reliable. And finally, the transplant may be delayed. We can do a diagnostic evaluation of a donor with latent TB to decide if they have unrecognized active TB, and then we can treat them before organ donation. So it's very useful in the living, but not the deceased donor population. So the consensus group recommended that donors with an indeterminate or positive test should not be excluded from donation. They should be screened for active TB. It's felt that the highest risk of transmission to recipients is unrecognized active, not latent TB. And IGRA testing may be used to follow and offer treatment to the recipient. However, donation should be deferred for active TB. And in some countries of the world, TB is so common in an area where transplantation is used that this is a real issue. Molecular testing of deceased donors is increasingly available and can be incredibly helpful. It's recommended that all lung donors be screened by bronchoscopy with AFB smear and culture. Nucleic acid amplification is preferred because the results obtained are rapid, and even in high TB incidence countries with less access to some of the molecular diagnostics, expert MTB-RIF, the very newest testing available in developing nations is more available in some of these locations, and results can be obtained in less than 2 hours. This is particularly helpful. These are results even on unprepped sputum specimens. And not only will you know if tuberculosis is present, even with good performance in AFB smear negative sputum, but you also can find out whether rifampin resistance is present. This is really an issue in some places that are now performing organ transplantation. So now we're going to move on to the final section of this webinar. This is the thing you're probably most likely to be asked to be involved in personally, and that is TB management of the transplant donor. And we're going to look at various scenarios to try to drill down kind of what the consensus has been in the transplant community in case you are asked. So you have a donor with a history of tuberculosis exposure or significant risk factors who's never been tested. This is pretty common. The TB risk is variable. For a living donor, it's very simple. We test them. For a deceased donor, we don't really have a test for which there are data to show that it performs well. So we monitor clinically. We try to flag the recipients as being maybe a little more high risk. With a history of latent TB treated appropriately, the transmission risk is lower. We can therefore monitor the recipient clinically. With a living donor, we can make sure we have records that that latent TB treatment occurred. And with a deceased donor, we monitor the recipient, but the risk is definitely lower. What about the history of latent TB that was either treated insufficiently, not treated, no documentation because it occurred in Cuba or in South Korea and nobody really knows, or a new diagnosis of latent TB infection with no evidence on screening of active TB? Well, this is considered a moderate transmission risk. In the living donor, we'd like to defer transplant until the donor has taken some latent TB infection treatment, or we consider treating the recipient. In the deceased donor recipient, we would consider treating for latent TB, and we'd certainly recommend latent TB infection treatment of lung recipients. Well, let's go on to some other scenarios. We have a new diagnosis of latent TB infection that's just made during the pre-transplant evaluation. There's no evidence of active TB, so it's moderate risk. Again, we'd like to defer. We'd like to consider treatment of the recipient and treat all lung recipients. A common scenario I get called about is unexplained pulmonary fibrosis in a donor without cavitation, without additional testing. The first thing we want to do is rule out other causes of apical fibrosis. We have other infections that can cause this that are transmitted through transplantation, such as the endemic mycoses, coccidioidomycosis, histoplasmosis, blastomycosis. So we'd really like to know if the donor has one of these. And we also want to rule out malignancy, which can be transmitted through transplantation. Transmission risk is therefore variable. If you're in an area with endemic cocci, this apical pulmonary fibrosis may be more likely to be an endemic mycosis. So with a living donor, we defer donation and we get the evaluation done. But what about the deceased donor? We've got someone whose heart is failing, they're on the list. What can we do? Well, we can perform a bronchoalveolar lavage on the potential deceased donor and try to get tests done as rapidly as possible. And while the tests are pending, we decide whether this donor is high or low risk for TB and whether we can offer these organs. If all definitive tests that we can do in the timeline are negative, we would accept them as a non-lung donor but consider actually full treatment of the recipient while we're waiting for the BAL results. And we can always scale back the treatment to latent TB treatment or other, depending on these results, which hopefully will be molecular results and rapidly available. What about the donor with the history of active TB? This is much, much more common in sites that are more high incidence countries. So they've had active TB in a site remote from the transplant, like a pulmonary TB in a kidney donor that was treated appropriately over 2 years ago. This is tremendously common in some parts of the world. Well, we know that most relapses occur within 2 years. So if it's been 40 years ago, the transmission risk is really lower or moderate. For a living donor, we can monitor the recipient clinically and culture the previous TB sites if possible. Though, mom might not really want to undergo a bronchoscopy before donating her kidney. If we can, we try to do cultures. We certainly try to get records to verify adequate treatment. And if in doubt, we treat the recipient for latent TB infection. And that's commonly done in these higher TB incidence countries. We do the same thing in the in the deceased donor. What about history of active TB? Again, a site remote from the transplanted organ, but within 2 years of treatment. Still lower to moderate risk. Again, we really want to culture the previous TB sites if possible, because this is the time where we see relapsing occurring, and this is where we really consider or suggest latent TB infection treatment of the recipient, especially if we don't know for sure that the donor was adequately treated. We do the same thing in the deceased donor. On to active TB that was treated insufficiently or with a non-standard regimen, and we exclude disseminated or central nervous system TB, which we would not consider appropriate for donation. Well, the transmission risk is, of course, higher. We know this person had active TB, and especially if less than 2 years since the active TB diagnosis, they're very high risk for transmitting infection. We would defer a living donor. We would make sure that an infectious disease specialist was involved in treating them, and we would culture the TB sites prior to organ procurement and transplantation. For deceased donor, it's more challenging. We would recommend treatment for the recipient, cultures of the previous TB sites in the donor, and involvement of infectious disease early so that the recipient can be monitored. In the rarest of rare cases where there's active TB in the same site as the transplanted organ, there's a moderate transmission risk. This is unusual because you can have scarring or fibrosis of the organ, but in transplant centers in Mexico where genitourinary TB is common, it is still possible to have a potential kidney donor who had more ureteral TB. And again, we want to verify that the donor was treated adequately. We want to treat the recipient, at least for latent TB, culture the previous TB sites. This may involve urine cultures, and keep infectious disease involved. For the very highest TB risk donors, it is recommended, even with the long transplant waiting list, that deceased donors be rejected and living donors be deferred until adequately treated. These are the cases considered highest TB risk: anyone with active TB at the time of donation, anyone who has a positive TB culture or nucleic acid amplification. AFB smears are a little more challenging because there are non-tuberculous mycobacteria, so that's really more of a you need to weigh who the donor is. But if the culture or amplification is positive, those donors should not be used. And if findings suggest possible active or latent TB, but no special cultures or molecular studies are available pre-transplant, those donors should be declined or deferred. Now, these are some very scary algorithms, but this is really just a summary of the data in the tables I've presented. And if you want to have something that you can use when you get a phone call, it's this algorithm and the next one. The table 6 it's referring to are the tables I just went over with you. So just to be brief, you've got a living organ donor. If their screening tests, which should be done, are negative, you proceed with donation. If they have active TB or a history of treated active TB, you go through the table we just talked about. And in the commonest situation that I see, that is, you have the positive test and you have time because they're a living donor, you want to make sure they don't have active TB. And if there's any question, you want to get cultures and diagnostics and make sure that they don't have active TB before proceeding with donation. If all your screening is negative, you can then treat the living donor with chemoprophylaxis for latent TB and proceed afterwards with donation. And then the timeline is guided by the need for the transplant to occur in the recipient. For the even more scary-looking algorithm, the deceased donor, low TB risk, negative imaging, you accept as donor. Remember, transmissions have and can occur in this scenario, but at least we feel a little better, especially if we have a good history that shows they're low risk. For active TB, we recommend rejecting. For a history of active TB with inadequate treatment or incomplete or unreliable history of treatment, we recommend rejecting. But in dire circumstances where there's someone who's dying waiting for their heart or liver, these organs have and can be accepted with involvement from day one in the treatment and management of the recipient, who may require actual treatment as if they themselves have active tuberculosis. If they have a history of active TB, we want to make sure there's a history of treatment, and we want to culture whenever we can. If there's imaging suggestive of old TB, this is a deceased donor, we may not have good history, we want to get some data collected. If it's negative, we can proceed with informed consent from the recipient site and the recipient, and if it's still pending, we decide which is worse, declining this organ, staying on the waiting list, or accepting it and watching what happens, and accepting as a donor with a plan to make sure final culture results are communicated. So in summary, 1 out of 3 of the world's population has latent TB infection. The transmission risk is really highest with unrecognized active rather than distant latent TB. Unfortunately, our currently available diagnostic tests have not been validated in the deceased donor population and may not be terribly useful. And most importantly, they don't distinguish between active and latent infection. And our real goal is identifying recipients of high-risk donors for close monitoring so that as soon as any symptom arises, the recipient center is thinking about tuberculosis and can make an early diagnosis and initiate treatment. Many patients die on the transplant waiting list. Few die of post-transplant infection. We are not going to make our transplant donors sterile or perfectly safe, but we need to involve our colleagues, such as all of you on this webinar and the TB community, to assist us in managing this very vulnerable transplant population to try to improve outcomes. And I want to thank, as part of this webinar, the people I had the great honor to work with in the Consensus Conference. Much of the data I've presented here is from this endeavor. You will see some of the leaders in the world's TB and transplant community, people like Neil Schluger at Columbia, is a great leader in tuberculosis management. Sung-Han Kim at Asan Medical Center in Seoul, South Korea. George John, who practices transplantation in India. Camille Cotton at the Mass General, who deals with a lot of these questions. Without them, we would not have pulled together this management algorithm for you. Finally, the world really is flat. This is a picture I took last November, the Pudong district of Shanghai, China, when I was asked to speak to a group of over 1,000 Chinese radiologists and infectious disease specialists to talk about transplant-related infectious diseases. So more and more of our world is sharing organisms all over and sharing technology, the wonders of organ transplantation all over, and I am so glad to be able to team with all of you to try to make this process safer for all. Thank you so much for your attention.
Michele, that was fantastic. Thank you so, so much. I mean, I have to say, I think that Robert Koch would be pretty much amazed, at where we've come, and your pictures around the world, I mean, it's the world coming into our living room, it's not just being flat, but reminding us how it's flat and getting smaller and smaller, and because of that, I think the great news is that there's so much hope for so many people who are suffering from such very chronic diseases where transplant's the only possible solution. But on the other hand, I think you'd agree, we have some challenges, So talking about some challenges and stuff, what we'd like to do now, we'd like to open the floor for questions. Questions will be taken on a first-come basis and will be answered given the time allotted. You may ask your questions online or by phone. Instructions for asking your question online are on the screen. And the operator will now provide instructions to ask you a question by phone. Operator, can you help? How can the audience ask some questions?
Yes, thank you. Ladies and gentlemen, if you would like to register for a question, you may press the 1 followed by the 4 on your telephone keypad. You will hear a 3-tone prompt to acknowledge your request. Your line will then be accessed from the conference to obtain your information. If your question has been asked by another and you would like to withdraw your registration, you may press the 1 followed by the 3. If using a speakerphone, please lift your handset before entering your request. Once again, it's the 1 followed by the 4 on your telephone to register a question.
All right. So what I'd like to do is I always like to start the questions, Michele. So, one of the biggest things we have issues with is that we have a patient who needs a transplant, and they're waiting for an organ, but yet they found as part of the evaluation that the person has a positive skin test. I guess the first question we ask, personally, I like to try to use a regimen that I can get accomplished the quickest. So usually we try using like a rifamycin. The problems with the rifamycin regimens are some of the drugs potentially they're on interfere. Do you have any, like in your experience when you're dealing with it, what is your approach to, how to treat the recipient who has a positive PPD or IGRA?
Well, I think what we have to weigh is the recipient's level of compliance, the acuity of the illness that's bringing them to transplantation, whether or not they have reasonable hepatic function, and where they are on the transplant waiting list. There's some lack of predictability, but at Miami, our kidney waiting list is roughly 2 years. So we have a little more time than if someone's in fulminant heart failure in the ICU waiting for a heart, where they're of necessity going to be treated post-transplant. I generally offer folks who are sort of in the middle multiple regimens. This is where we get into sort of the off-label sort of use. The rifampin, the rifamycins are wonderful, and a 4-month course of rifampin is fabulous. It is not as fabulous as you'd think because people waiting for organ transplant are not healthy. They're usually on a laundry list of medications. Most of our potential heart recipients are on Coumadin and antiarrhythmics, which interact very significantly with rifampin and also sometimes with isoniazid. Most of our potential kidney recipients are on antihypertensives, on oral hypoglycemics. So one of the first things I do is plug every single one of their meds into my computer because I can't keep it all in the brain, and I start testing isoniazid, rifampin, rifapentine to kind of see what looks like it might work. And I try to make sure they're going to be able to kind of be compliant with the regimen. The 4-month rifampin is something that I love. I offer it to a lot of people if we can manage the drug interactions. If I'm going to treat someone who's on Coumadin, I personally call the cardiologist who's managing the Coumadin, tell them that I'm starting, tell them the date I'm starting, so that these people don't bleed. Every once in a while they do anyway. So really being attentive to drug interactions is important. And then I tell the potential recipient that we will not be able to complete this course post-transplant, that if by some amazing situation they get an organ offer before the 4 months are done, we're going to have to make some decisions post-transplant about how to manage them. For the potential liver recipient, the issue is hepatic function often. Isoniazid is an option, rifampin is an option. Even isoniazid and rifapentine is an option. This is totally off-label. I tend to use the combination for the healthy potential donor who is able to, in an organized fashion, comply with the once-weekly dosing, and does not have drug interactions that are going to bump up and down every week when they take their drug. But I really try to partner with both potential living donors and recipients to individualize the regimen.
I totally agree. I mean, just some comments. I mean, I think one of the most important things I find in it is communication. And I think you pointed out very well. I think one of the hardest things is getting all the doctors together on a single page and explain what you're going to do it and why. I mean, one of the key things we try to do is get the transplant team, plus all the private docs, or the treating docs, I should say, so we're all in agreement so we know what to look for. You know, I like to use rifabutin in certain times because there seems to be less P450 interactions, but I think you'd agree nothing's perfect. But I wanted to ask you, and then we're going to go on to the question, what about the use of therapeutic drug monitoring? You know, one of the things from time to time, in order to handle these interactions, which can be so severe, you know, the use of like therapeutic drug levels on both the rifabutin as well as the other drugs, especially once they're transplanted. Any comments on that? I think it's something, again, that's up and coming. There's, like you said, not written in stone yet, but I think something that may be very helpful in these kind of cases. What do you think?
I would love to have more access to therapeutic drug monitoring, particularly treating the transplant recipient. On that end, where I'm treating either for latent or active TB, it's an incredible challenge.
Right, I agree. I mean, I think the access is the biggest issue, you know, but I agree. So let me get some questions. I got to say, we're getting a lot of questions, so and I have a ton, but I want to go to the participants. John Washington from Tennessee has, you know, talking about interactions and stuff. He's asking, although some patients awaiting lung transplant are immunosuppressed due to the high dose of steroids they may be on, why not routinely screen for LTBI with an IGRA? And, you know, his preference would be the quantiferon gold, you know, in tube due to the mitogen results. So, you know, you almost have like that built-in antigen theoretically or not, you know. And he says, you know, from the, and his rationale is from the perspective of a public health contact investigation. We're asked to determine whether TB disease in the recipient was secondary to the donor reactivation or was this transmission from the donor. And he feels that this information, if we had it prior, may help in you know, the, what do you call it, in the determination. And obviously, even though the positive predictive value and the sensitivity may not be perfect, you know, it's the old story, you know, for us in TB, nothing, especially we do with these tests, are ever perfect. Any comment on that? I know there was a lot of debate.
Right. Well, I think what you need to remember is that what I was talking about today, the transplant donor screening. So in most of North America, we do screen 100% of our potential organ recipients. And anyone who tests positive, and some subset who test indeterminate, but we are concerned, and even some who test negative, but we believe are high risk based on imaging or their history of potential exposures. We do treat for latent TB after screening for active TB. So I agree 100%. And the great beauty of the interferon gamma release assays is we do have this mitogen control. So we do have an indeterminate status. And a lot of my practice is involved in treating people who are potential organ recipients pre-transplant. We do not have that luxury of time with the donor, and the deceased donor is often far more immunosuppressed than the potential recipient because they are legally brain dead, and the timelines are different. So for sure, I think the IGRAs are an incredible advantage for screening potential recipients.
And it's kind of interesting. I mean, among the TB community here, you know, we really are, you know, getting more and more familiar and more accustomed to IGRAs, and I would say we're having like a ton of questions about the IGRAs. And I know when we've discussed in the past, there was a lot of discussion among this consensus, and I think a lot of it was depending on understanding it wasn't perfect and there would be shortfalls, and the importance of not losing an organ. I mean, that is like one of the key. But a couple questions, if I can, just you know, one is that they're essentially saying, is there consideration to requiring an IGRA such as quantiferon for latent TB and screening on living donors? So we're requiring an IGRA for living donors, or please.
In Miami, it's required. It's part of our practice. The recommendations are changing for screening donors in the United States. Right now, the main issue, which is actually being debated in our national legislature, is the issue of HIV. So that the high-risk donor since the early 90s has been the HIV-positive donor. Other countries are actually transplanting HIV-positive donor organs into HIV-positive recipients in places like South Africa. And incidentally, talk about a high risk of TB in the recipient population. Wow. They get uniform isoniazid, sometimes lifelong, in those kidney recipients. But for sure, we do screen all our living donors, and I think that the majority of centers in North America do as well, and there's time to treat them.
Right. Well, I understand if we have actually a call on the, we have a question on our phone lines. Operator, would you please patch in the call, please? And call, remember, push 1 and then 4.
Yes, thank you. And yep, as a reminder, it's 1-4 to register a question. Our question is from the line of Mark Lobato. Please proceed.
The question's been asked already and answered. Thank you.
Mark, thank you very, very much. I appreciate it. Thanks for listening, too. We have a quick question here that, which is that, have we seen any changes in the prevalence of TB morbidity in recipients in the U.S. since the introduction of IGRA? Do we have any data whatsoever on how IGRA may have, or the screening has in any way affected the number of cases of TB among our recipients?
I think that's a wonderful question. I would love to know the answer. I think the issue is that looking at donor-derived TB is kind of a new topic. In other words, the Disease Transmission Advisory Committee was just convened a few years ago, and the definitions were obtained. And so it sort of happened around the time that IGRAs came into wider use and became more available. The turnaround times became a little better, a little more rapid. So it's very hard to tell. Reports are actually going up because it's now law in the United States that you report any potential transmission. So, if we go by reported cases, it is not declining. But in fact, we can better understand how to prevent transmissions by really getting more than the tip of the iceberg in information.
Great. Sheila asked a really interesting question, which is, if you have a living donor from overseas and the recipient dies from TB in this country and the donor organ was from overseas, what do you do? I mean, is there any mechanism, or does that happen that organs are coming from overseas to here, or, issues with international transplantation between countries?
I can't speak for the Eurozone. They may share organs. In the United States, the only overseas I know we get organs from is Puerto Rico, which is a territory of the U.S., and we get lots of organs from Puerto Rico here in Miami. But to my knowledge, there's plenty of transplants being performed in other countries, but the organs stay in those countries. Now, there are a lot of Americans who travel overseas doing something called transplant tourism. It's something that the various societies of transplantation very much frown upon. Often there are poor donors, prisoners who are paid or convinced to donate organs, and people pay money to not have to die on the transplant waiting list or not have to wait for their kidney and get sort of a black market organ. And there's been definite cases of TB transmitted through transplantation of these organs to U.S. nationals, but the transplant surgery occurred overseas.
Right. Now, in those kind of cases, I guess the question is, if the recipient develops TB in this country, is there any mechanism or any attempts to try to get back to the donor to notify them, or is that not in place? I know this is kind of outside the usual mechanism.
I mean, it is very black market. I've cared for various complications in these recipients, including malaria and CMV, never TB, though any person who illegally purchases an organ overseas need to be followed and screened for TB and HIV and hepatitis and sort of everything under the sun. This is very much black market, even in the countries they occur. So there's a lot of these people are pulled off the street, given whatever, $100, we're taking your kidney, or perhaps they're prisoners and there's no choice. And so, I don't think that there's an easy way to trace.
Right. Yeah, sure. Another question from John. He's asking, among U.S.-born solid organ donors and recipients, our experience suggests that veteran status may be a risk factor for development of active TB in the recipient. Have you encountered this? Maybe the system here would be familiar.
Sure, that's a great question. That did not come up in the consensus conference. I think it's an excellent question whether veteran status, independent of living over 3 months in a endemic area, independent of the other risk factors, which unfortunately may be occurring more often in veterans. And I don't think that data is available. If it is, I'm not aware of it. But certainly many, many veterans have spent time, and I ask every single person referred to me, were they ever in military service? And we have lots of people who were military service, for instance, in Angola when they lived in Cuba. I mean, so there are people who have served for their country, which is not the U.S.,
right,
and they have risk factors beyond their country of origin. That's really important when you're trying to get a history, again, on a deceased donor from a relative. Did they have military service in another country when they were living in France?
Right. Yeah. So here's one of the questions that we're getting, because some of the hardest things would be making the diagnosis of active TB especially in cadaveric, donors, but the question is how sensitive is the NAA in smear negative BAL or sputum? I mean, is there any difference in transplant donors than what we see, would you say, in the normal population? Do you think it's any higher or lower? I mean, or are we dealing with the same, problems with that NAA that I think it's from my perspective, it's not a perfect tool, but when it's positive, it's helpful. I mean, is there any difference?
I mean, I don't know that there are data. I can tell you that we do bronchoscopy on donors where there's a question, and we do rapid testing, but we always do smears and cultures. So it's certainly not ever managed independent of culture and smear and more gold standard. I mean, the advantage is these donors are are on a ventilator unless they're a donation after cardiac death type donor, which does occur as well. And so we can do a bronchoscopy and obtain plenty of specimens and obtain good specimens to evaluate. And so I think the performance should be similar to what it is in an ICU setting.
Right. I think it's one of those situations that, it's not perfect. I think, if you look at the literature, it runs anywhere from about 50 to about 60% in smear negatives, maybe depending on, like you said, the quality of the specimen. But if it's positive, it's much better. It's helpful. I mean, if it's in negative, you just don't know what to do with it. There's a clarification. Remember the question we were asking before about what if the donor was from another country? And Sheila's actually going on to tell us a little of her own experience and scenario, that they had a case where the living donor came to the United States to donate for a cousin. So the thing was, this was somebody, I guess, who came from outside the country, came here, and this was designated as a living donor transplant, which was done in the United States from overseas. So I guess that was the clarification. I take it, though, that the recipient must have either gotten TB or unfortunately may have even died from TB from the first one. And I guess the question is, is there any mechanism, or, what would be the responsibility of getting back to that cousin back in her own country?
I mean, there's always a responsibility to living donors who've been generous enough to donate their organs. I think when a relative flies in to donate, which is not at all infrequent, especially with our global world, we screen them. We do testing, and we don't just do either skin test or IGRA or both, but we also do imaging of their chest, even if they're a kidney donor. And they're pre-op. They're going to have a big surgery, probably bigger than their organ recipient friend or relative is going to have. And if there is any question at all on chest x-ray, especially if there's any question of TB based on country of origin, we do a CT thorax. The group in Seoul, Korea actually has looked at CT thorax in a country where it's a 40+% incidence of latent TB in the population, and it is better. So we don't want to expose our healthy living organ donor to radiation unnecessarily, but we use that to clarify risk, and if there's risk, we will treat the donor, right. or if it's an urgent transplant, the recipient.
And, I think you touched upon this before, but a specific question, do we have any idea what is the incidence of mortality in the recipient population on TB therapy? I mean, those that are diagnosed, even if they're treated, I think there was quite a significant mortality even despite therapy.
Yeah, now that with therapy, with diagnosis and therapy, mortality rates in the literature range from between 20 and 30%. It's very significant. The diagnosis is often very much delayed. And you saw by the cases I presented how unusual the presentation is, and these are not normal healthy people. In general, with donor-derived TB, these are people early post-transplant when many, many other much more common infections present.
I just want to remind everybody just for 1 second that if you have any questions, please, like you're doing, please put it in the chat or put it in the Q&A, and I'm seeing them. I'm hoping I'm getting them to Michele. And also, we'd love to hear from you. It's a lot of fun to hear from you on the phone. So if you have a question you'd like to ask Michele personally, please ask the operator, push the 1 and the 4 to register your call, and then the operator will tell us that you're there, and we'd love to hear from you. Again, I also want to remind everybody that the recent consensus report that came out of the American Journal of Transplantation that Michele and her colleagues co-authored came out in September of 2012, and I highly recommend it. What was your experience putting this together? Because I think you'd agree the consensus is anything but a consensus. I think there was probably, especially with the debates about skin testing and IGRAs and the concern, because I think what's very interesting, what you're hearing from this audience is a tremendous, desire to test everyone, because I think there's a feeling among us that if you had a knowledge of the recipient, even if it's not perfect, but if you knew that it was, that they had the evidence of latent tuberculosis infection, I think none of us would suggest not using the organ. To us it's very weird. It would be that the recipient you would consider maybe treating. Granted, there's a lot of problems with treating, but I take it that wasn't quite uniform. There was a lot of concerns, I take it, about cost of the IGRA, as well as I think, if I may, the potential loss of organs, which must be a major concern in the transplant community.
Well, I think that actually with living donors, everyone agrees because we can do the test. I think you have to remember who the deceased donor population is. Someone gets hit by a bus, someone develops a cerebral hemorrhage. By the time we know they're an organ donor, the clock is ticking. We have, if it's a thoracic donor, about 6 hours from that moment to when the organs are out. And we got a lot of things to screen for while we support them. So while everyone on the consensus, including people from very high TB endemic countries, would love to screen all of these people, even just to know they had latent TB, there really isn't time, even with the best tests, even if the performance was good, and these people are legally brain dead.
Right. I guess the question is, and don't get me wrong, I understand the limitations of legally brain dead, that these tests may not work as well. But I guess the question is a little different. I don't think that the question among the group, the TB community, is use the screening to see if they can I think you transplant the organ no matter what. The question is if you at least drew the blood before you did the transplant and the blood came back as positive, it would give the treating clinicians the option after transplant to know if they needed to treat or not. So I do agree. I don't think you can ever, or would you ever want to wait for these results? I think that's useless. I think you got to go ahead, because the person's infected. You're not going to see, but I guess the question is, if, at least if you knew it was positive, and again, this is one of those situations that if it's negative, it doesn't really matter. You know, it's not going to help you, but if it's positive, it may give the treating physicians the option of considering treating the recipient before they potentially could get the disease.
Well, the couple challenges there. One is many potential donors have received 30, 40, 50 units of blood.
Right, that's true.
So their blood is not their blood.
Right.
Their blood has been exchanged many times over in the trauma that led to transplant. So we know the performance of HIV, Hep B, West Nile, all the assays we have, which are not dependent on immune response, but are actually measuring pathogen, virus in blood, very poor. And we have a huge percentage of donors who've had over 30 units of blood. So that's one issue. And another issue is there was concern that it will lead us away from the truly high risk by looking at the things we know predispose and lead us to, you know, overtreat with very complex drug interactions and potential organ loss and morbidity on the recipient side, people who are much lower risk, rather than saying, you had a donor who was a homeless alcoholic, and you are high risk, and we know that. Those statistics we know. This test performance has never been validated, and every study to validate it, and they're trying to do that in the Eurozone, has failed.
Right.
It has not been predictive. So until to mandate, I mean, we do lots of expensive tests in blood donors. In organ donors.
Right.
I mean, that's not the issue. The issue is if we end up barking up the wrong tree, looking the wrong direction, and miss the importance of really recognizing a high-risk donor, we expect that the performance of these tests is going to be pretty lousy, and that we might be able to do better with a good history and physical and some gold standard testing pre-organ procurement.
I think you're preaching to the choir here. We've known the limitations of those tests for a long time, and we totally agree. Hey, I understand we have a couple of questions on the phone. So, operator, would you ask for our first question, our next question on the phone, please?
Yes, thank you. Our question comes from the line of Risa Webb. Please proceed.
In the recipient who is latent TB positive and did not receive latent TB therapy prior to receiving their transplantation, when would you start LTBI therapy?
Excellent question. I scratch my head about this a lot. They need to be able to swallow pills and to be compliant. If they're a liver recipient, we would like their liver to be functioning reasonably normal, and it can take a few weeks, especially with people who have some delayed allograft function. The main thing is we don't want to lose track of them, have them discharged without being consulted. And then we have to also have in mind what immunosuppressants they're on so we can deal with drug interactions. If they're a kidney recipient, which is the most common transplant, we'd like their renal function to kind of have settled down so that we don't have too many different things influencing their immunosuppressant levels that we're going to mess up with our latent TB treatment. And we do not ever use rifampin for latent TB treatment post-transplant. We do use it for active TB treatment. Usually we use rifabutin, that rifamycin with less drug interactions, as Dave mentioned earlier. So in general, we're using isoniazid in these patients. And I have to say also that people do not have to complete 9 months of isoniazid before they are an organ recipient or even potentially an organ donor. We like to get as much in as we can, and I've had many patients where we've started, they got an organ offer, and we complete it post-transplant. We use the same guidelines you probably do. We try to do less than 2 weeks of interruption, and then we get it restarted.
Great question. Thank you, Dr. Webb. Thank you so much. Thank you for calling in. Operator, I think we have, I'm sorry, Dr. Webb, do you have a follow-up question?
I was going to ask also if you had someone with active disease who had received a transplant or they received an active disease transplant, and you were starting them on active therapy, would you start rifampin initially, or would you wait and add that and maybe use a quinolone in its place if you could avoid drug interactions with that?
It depends. This is when I call you all. I call my colleague David. But I mean, I've used rifabutin. I tend to try to use erythromycin. The problem with the quinolones is everyone and their brother has had fluoroquinolones. And particularly in our liver recipients who have fluoroquinolone prophylaxis for spontaneous bacterial peritonitis, they have seen a lot of quinolone while they were waiting for their transplant. And if they have latent TB, it has seen a lot of quinolone. So I don't trust it.
Yeah, I agree with you 100%. I mean, that's where I think, again, communication with the team. I mean, I can't emphasize that enough. I mean, I find one of the most helpful things to do is get everybody together and see what's best for that patient, because I think every patient's a little different, just like you're getting on. And I don't think there's one answer, but I think the key is that communication, and like you said, that's where we have used therapeutic drug monitoring if we have to, in rifabutin and other alternatives. So those are great questions, very practical, and I think, unfortunately, when you're looking at guidelines, I think the guideline is, every case is somewhat different. Dr. Webb, any other questions?
That's great. Thank you.
Hey, thanks, Dr. Webb. I'll talk to you soon. Operator, I think, all right. I think we have another question on the line. Is that correct?
Yes, thank you. We have a question from the line of Heidi Epstein. Please proceed.
Oh, hi. I have two questions, actually. But one of them, if we have a patient, I'm going to give the example first, so my question I hope makes more sense. But if we have a patient that we're treating for active disease right now, and the patient expires before completion of therapy, is there, and they expire, I wouldn't know personally is at the time of their death, if somebody approaches the relatives and they decide they're going to donate the person's organ, and the history taking sometimes is poor, as you mentioned, and the relative doesn't know that they have TB, do you guys match up people to a database? I mean, in other words, how would you know that they were halfway through therapy for active TB, especially if the person given the history post-mortem doesn't even know they were on medicine?
You've touched on one of the major challenges, and there is no linking of the database, sadly.
Okay.
But there is about, a 10 to 20 page questionnaire that every OPO goes through with whoever they speak to, in addition to speaking to the ICU or emergency room staff. So every effort is made to try to avoid that scenario.
Okay. All righty. And my other question was, if we have a patient locally who has active TB who's post-transplant, and they have active TB, actually it could be in a different organ, but this one happened to be in the same organ that they had the transplant for, is there, and forgive me if you brought this up and I didn't hear, but is there some kind of reporting system and kind of investigation that you go back to? Of course, our priority is to treat that active case right now, especially a post-transplant, but is there some kind of required reporting or investigation to look back and see if this could be donor-related? Or?
Yeah, I mean, there is actually federal law that requires that this case be reported to the center where they were transplanted. And if you know where the organ came from, which most recipients do not, to the organ procurement organization, and time is of the essence. So if there's anyone on the call who's treating active TB in a recipient, particularly within the first year post-transplant, but not necessarily, that needs to be reported to the center where they were transplanted. It is an emergency because not all of the other recipients of organs and tissues may be aware of the risk.
So we report it to the transplant center, and then you touched a little bit on the time frame. How about if it's somebody, let's say somebody was transplanted in the last year or so versus somebody was transplanted 6 years ago? Either way, we want to do that because there's going to be some investigation or some looking back at that.
Well, 6 years later, it's extraordinarily unlikely that it will be
Yeah, I know it is. I'm
donor-derived.
just, yeah, right.
But
right.
it's much more likely that it's community
Mm-hmm.
acquired. Activation generally occurs within the
Right,
first half. But it's still very useful. All transplant centers keep track of this data, and it's very useful to them. And they should be involved anyway if they're monitoring immunosuppressants.
Just to follow, it's interesting on Heidi. And Heidi, how's everything going? It's good talking to you. But just a follow-up, one of the things we found with, now that we're doing pretty much universal DNA fingerprinting in the state of Florida, one of the ways we picked up on a recent transmission was through a fingerprint match that when they did the epidemiology, they couldn't figure it out. When they went back and they looked at the two individuals, they realized the first person was a donor. So I think there's still a lot of, and we got a couple different, questions and comments about that. It would be, in the perfect world, it would really be nice if there was some way to have access to all these different databases, but that is still an issue. Heidi, thank you so much. Operator, I understand.
Thank you, Dr. Morris. It's very good.
Operator, I understand we have another question on the line. Is that correct?
Yes, thank you. Our next question comes from the line of Jermaine Jacquet. Please proceed.
Hi, Dr. Morris, can you hear me?
Yes.
Yes, thank you for that fantastic talk. We really appreciate it. I had a question about the kidney donors because I've seen a number of cases of GU-TB that was probably occult for many years and just serendipitously found with a CT for other causes. And so I'm wondering if the kidney donors, especially those from high prevalence countries, get AFB cultures before donation and to pick up what may be occult early stage GU-TB.
That's absolutely recommended, and unfortunately not every center, imaging is of course done to all potential donors. Sure. And not every center has a radiology team that would recognize the sort of prototypical signs of GU-TB. So really it is not a mandated part of the protocol, but certainly with Mexican donors in particular, we tend to look for AFB cultures of the urine. But that, if a transplant center, as the world is global, needs to really look at that imaging to look for those signs, because from what I understand from my radiology colleagues, there are some pathognomonic changes and they might be missed. So It is quite important. Thank you for raising that excellent point.
I would also recommend it in Ecuadorians, where I've seen a number of cases of GU.
Mm-hmm. Thank you.
How just based on, just follow up on that question. How is resistance, affecting? Because like one of the issues you said before, somebody had a history of active TB before and treated, but most countries are really not doing susceptibility, and what we assume to be a treated case. I wonder how, especially in countries where multi-drug or drug resistance is greater, how that's affecting. Do we have any data on that at all?
Well, there's some published data. I mean, it's a big challenge, but as the resistant TB population starts to cross the organ transplant population, my colleague in Seoul in South Korea tells me that they have a 9% incidence of isoniazid resistance. Right. So they screen, but they do not prophylax. Right. And I have visited their incredibly elegant transplant center at Asan Medical Center, and it's it's the nicest transplant hospital I've ever been to in my life. And what they do is they just follow people clinically. They do not give treatment for latent TB, but they are so good at diagnosing tuberculosis in all of its manifestations very early, and they just are so concerned about resistance that's how they manage it, and they're good at testing.
Right. I got to be honest. This is just fantastic. What a great presentation. I mean, I could go on as I usually do. When we do get together, we go over cases, case after case, and what's really great about this is just constantly evolving, and I think that's what's going to continue. So I'm hoping that maybe in the future we can get you back and give us an update on what's going on. But with that, I can't thank Dr. Morris enough for what an outstanding presentation, and thank you for bridging that gap or the islands between us TB guys and the transplant team. So thank you very, very much, and thank you for an outstanding presentation. what we're going to do now is we're going to conclude. I want to just say to all of you, on marking this 131st year of Rob McCoke's announcement and World TB Day, I want to just personally thank each and every one of you for everything you do for tuberculosis and helping keep the community safe. As you know, we're going to have a number of upcoming events and courses, and they're texting right through. As you can see, if you have any further questions that you'd like to have answered, if you email us, we'll get them taken care of. But other than that, I just want to thank each and every one of you, and I'm hoping to see and talk to you guys soon. So thank you for everything. Have a great afternoon, and we'll see you soon. Thank you.
Take care.